Today we have the pleasure of hosting Dr. Alice Levine for a talk on adrenal hypercortisolism. Dr. Alice Levine is a professor of medicine in the Division of Endocrinology, Diabetes, and Bone Disease at the Icahn School of Medicine at Mount Sinai. She received her medical degree from Columbia University College of Physicians and Surgeons and completed her residency in internal medicine at New York University Manhattan VA Medical Center. She did her fellowship in endocrinology at Mount Sinai School of Medicine, during which time, under the tutelage of Dr. Lester Javila, she began her academic career, which focuses on hormonal neoplasia. They were the first to report on the successful treatment of benign prostatic hyperplasia with hormonal therapy. Dr. Levine also serves as co-founder and co-director of the Mount Sinai Adrenal Center. She has published extensively on the management of adrenal diseases. Dr. Levine is also a highly regarded teacher and has been the course director for the second-year endocrinology pathophysiology course at the Mount Sinai School of Medicine, as well as the director of endocrine, Grand Rounds, and endocrine fellows research. In 2011, she received the Mount Sinai Institute of Medicine's Excellence in Teaching Award. Please join me in welcoming Dr. Alice Levine.
That was really nice. Thank you, Yasmin. That was one of the nicest intros I've ever received. It was really nice. Okay. So today I'm going to talk to you about adrenal hypercortisolism, controversies in the diagnosis, prognosis, and management. I don't have any current disclosures. And I'm going to start with a case. So a 68-year-old female presented with what we call an adrenal incidentaloma, something which was noted on a CT urogram done for other reasons. And then she had a dedicated CT which showed a 2.8 centimeter left adrenal mass with Hounsfield units of -3, which is consistent with a benign adrenal adenoma. Past medical history was notable for many of the features of what we call the metabolic syndrome: hypertension, hyperlipidemia, osteopenia, impaired glucose tolerance. And of note, she had a weight gain of 25 pounds in the prior 18 months. This imaging shows you the adrenal adenoma, which is seen on the, let's see how I can do this, on the left side here. Usually the adrenal glands appear, of course, suprarenally as an inverted Y, or what's called Napoleon's hat. And if you look here, this is the small adrenal adenoma, and if you look at it just compared to the density of, let's say, the spleen here, it is less dense than liver, and that's compatible with a lipid-rich adrenal adenoma. So going on with the case, you see hypertension, no signs of virilization. There was possibly some increased dorsocervical fat pads, central obesity, but no striae, no classical symptoms of Cushing's. And on laboratory examination, basically what is notable really here is that the DHEAS is a little bit low. Midnight salivary cortisols are normal. 24-hour urinary free cortisol, which is usually our gold standard test, is a little bit high, but nothing really notable. Aldosterone to renin is normal. But the only real abnormality here is that after 1 milligram of dexamethasone the night before, the cortisol did not suppress maximally. So is this mild hypercortisolism due to an adrenal adenoma, and does it deserve any further workup or treatment? So this is what we classically know as Cushing's syndrome, what we all learn in medical school and beyond. And this would be somebody with florid Cushing's syndrome who has osteoporosis, emotional disturbance, the classic increased fat in the dorsocervical and supraclavicular area, central obesity, and hyperpigmented striae. If you look at all comers with florid Cushing syndrome, that's the ones that you could recognize from down the hallway. This is a fairly old slide, but for florid Cushing syndrome, this probably still holds up. And we divide Cushing syndrome into ACTH dependent, where it's driven by ACTH, versus ACTH independent, which would include exogenous steroids. So ACTH dependent makes up the majority of florid Cushing syndrome, whereas adrenal causes, where the cortisol production is sort of on autopilot, ACTH levels are very low, that would be the minority of patients with florid Cushing. So today I'd like to talk to you about what is somewhat of a different animal, which is adrenal Cushing. So I want to talk about the epidemiology, the biochemical diagnosis, the sequela, and the treatment options. So in terms of epidemiology, so this patient presented with an adrenal incidentaloma, which is exactly as the term sounds like. You went in there, it's like when you take your car in because you hear a funny sound and they say, oh, while we're in there, we found that the brakes were off. So this is what happens. People get abdominal imaging for any number of other reasons. And an incidentaloma is any serendipitously identified mass of greater than 1 centimeter in the adrenal glands. Autopsy studies suggest that these may be present in about 6% of all people. Incidence increases with age, and most of them are non-secreting, and the grand majority of them are benign. So we're not very worried, except in specific cases, about malignancy. Just a little sidebar, the Beatles are kind of responsible for the adrenal incidentaloma. So the Beatles, as we all know, made a ton of money in the 1960s because they were fantastic. And they recorded on EMI recording, which stands for, I know that Sal Silmy knows this, Electric and Musical Industries. So this was a company out of the UK which specialized in two things, music and biomedical research. So all that money from the Beatles was funneled in the 60s, and all that money really went to develop the first CT scan, the EMI, Electric Musical Industry Scanner, which was developed by Sir Godfrey Newbold Hounsfield in Britain. And the original ones were very crude, brain scans only, required a water-filled pre-shaped rubber head cap. It took days to do these and to assemble the information. Dr. Hounsfield shared the Nobel Prize in 1979 for developing this. And very soon thereafter, a disease was born, the incidentaloma. So this is the first publication from 1979 from Korobkin et al. And it first appeared in the 1970s. And in this particular publication, they said that 19% of their patients that they had scanned had these little adrenal incidentalomas. So the incidence of this increases with age. Therefore, if you pick up one of these in somebody less than 30 years of age, because the incidence is so low, you have to be quite concerned about it. Greater than 70 years of age, 6.9%, but I've seen estimates up to 10% of these that are picked up. The overwhelming majority are benign, particularly if they're small. And again, there are certain radiographic features that can distinguish worrisome ones from benign. So what about hormonal hyperactivity? Now this is where the controversies begin. In a review by Bill Young in the New England Journal of Medicine in 2007, when they looked at all patients with adrenal incidentaloma, according to their definition at the time of hormonal hypersecretion, it was the overwhelming majority of them were non-secretory. And of the ones that were secretory, probably the largest piece of the pie were cortisol secreting, 4 to 5%. Well, what a difference 7 years makes. So this is from the Lancet by Dalmasi et al. And now, having changed our definition of what we consider to be adrenal hypercortisolism, it was reported, this is fairly recent, that up to 30% of them are making a little too much cortisol, not a lot, but a little. So this is the index case for Harvey Cushing. This is mini G. And you can tell this is an old slide because it's in textbooks and her face is not in any way covered. And this was what we thought of as Cushing's when we learn about florid Cushing's. So you see here increased dorsocervical fat. You can almost see that there are probably multiple vertebral fractures here from osteoporosis. You see this massive central obesity. I hope you can see the hyperpigmented striae here. And then wasting of the extremities. Harvey Cushing, though, was a neurosurgeon, so he was dealing with pituitary ACTH-dependent Cushing's, and again, this is very severe Cushing's. This is what a lot of our patients look like, a lot of our patients who are not adrenal patients. So this is the metabolic syndrome. This is increased waist size, increased visceral fat, and I can tell you this patient has hyperlipidemia, hypertension, and at least glucose intolerance, if not diabetes. So the question is this mild Cushing's? Is this subclinical Cushing's? So how do we define subclinical Cushing's? Let's talk about the biochemical diagnosis of Cushing. Cushing's syndrome, as you know, is exogenous glucocorticoids can cause it, and it's just too much cortisol. It can be exogenous or endogenous. And the screening test, the gold standard screening test that we all learned when we have a high index of suspicion for Cushing's is a 24-hour urine for urinary free cortisol. And if it's double or triple the norm, there's not much else that can explain that. Midnight salivary cortisols are also used because right before we go to sleep, if you're on a normal sleep-wake cycle, your cortisol levels should be at a nadir. And as I tell my patients, I'm not coming to your apartment and drawing your blood, so they've developed this very nice test, which is midnight salivary cortisols. Those two are urinary free cortisol, and midnight salivary cortisols are also free cortisol, so there's nothing about the binding globulins. When you measure serum cortisol levels, you're measuring total cortisol. So there you have to take into account the free and the bound. And when we do a 1 milligram overnight DEX suppression test, what we measure is blood cortisol levels, ACTH, and also a dexamethasone level to make sure that it's high enough to interpret the test results. But because it's total cortisol, and because birth control pills increase the binding globulins, you can't use a 1 milligram overnight DEX suppression test in anybody who's on a birth control pill. So what about subclinical Cushing from an adrenal source? So this is the mild, the slow burn hypercortisolism. It's different. They have an abnormal dexamethasone suppression test. That can be the only thing that they have that is abnormal. They may or may not have altered circadian rhythms. The urinary free cortisol is often normal or nearly normal, as in the case that I presented. ACTH may not even be completely suppressed, and that's an interesting phenomenon, but generally it's on the low side. So what about the 1 milligram overnight DEX suppression test? How do we define adrenal Cushing's? If we don't have the urinary free cortisols and the midnight salivary cortisols, what do we define as Cushing's? So the way I look at this, when patients present with an adrenal incidentaloma, and the only thing that you find is an abnormal 1 milligram DEX suppression test, in the past, the only choice that you had if you wanted to treat that, if you wanted to call it subclinical Cushing's and treat it, is to do a unilateral adrenalectomy, because they don't do selective adenomectomies. They take out the entire adrenal gland. So endocrinologists sort of fudged on this one. They felt like, well, I don't want to be taking out everybody's adrenal gland, so what I'm going to do is normally, a normal DEX suppression, you're really supposed to suppress to less than 1.8 micrograms per deciliter. That's if you have a high index of suspicion that someone has Cushing's. That's really being very stringent about it. That gives you a sensitivity of 75 to 100%, but it's less specific. So because we don't want to get false positives, a lot of the literature up until these past few years When they were looking at adrenal Cushing's, this mild subclinical Cushing's, what they did was they said, well, okay, I'll just be happy if they suppress to less than 5, which is not normal, but they decided that it was normal enough. And again, that gives you a very low sensitivity, but much more of a specificity. So this was a meta-analysis by Cialdini from 2011, looking at the laboratory definition of adrenal Cushing's, that different disease that I'm talking about. And people use dexamethasone suppression test cutoffs all over the map. So you see some that it just needed less than 5, and some that were traditional, less than 1.8. So when we interpret all these studies, you have to interpret them realizing that there are different definitions here of what they're calling subclinical Cushing's. So why is it important to even make this definition? What are the sequelae of mild hypercortisolism? There are a lot of sequelae, and there is a growing literature to tell us that any degree of hypercortisolism, any degree over time, is very deleterious to multiple organ systems. So first, and maybe foremost, adverse effects on bone. In the field, we know that even low levels of glucocorticoids over time, even very small doses, are very deleterious to bone cells, particularly osteocytes. Osteocytes are the mature osteoblasts that are embedded in the bone matrix, and they are the Obersturmbannführers of everything that goes on in bone remodeling. And so if you kill them, you've got a problem with your bone. And in terms of mild hypercortisolism, however it is defined, in 2007, Takmanova showed that there were increased vertebral fractures in patients with mild hypercortisolism on the order, the same kind of incidence that you see with florid Cushing's. And then in a larger study, which was done in 2011, 103 patients with 2-year follow-up, again, same deal, very much increased vertebral fractures in patients with mild hypercortisolism. Hypertension, there are quite a few studies over the years. Many of these are confounded by the fact that there are other variables going on in patients with mild hypercortisolism. In terms of insulin resistance, impaired glucose metabolism, body composition, and non-alcoholic fatty liver disease, there have been some recent studies which were larger. Most of these are retrospective, by the way. 2013, 2014, both of these studies showed increased in insulin resistance and prediabetes in patients with mild hypercortisolism. De Bono showed increased visceral fat accumulation, and again, on the same order of magnitude as patients with florid hypercortisolism when they had minor amounts of elevations. And Papanastes, I can't say that, showed non-alcoholic fatty liver disease in the same patient population. Of note, the duration of cortisol exposure is associated with an increased risk for morbidity and mortality even once you fix the problem. It's like the song is gone, but the melody lingers on. So this is from our own institution. One of our fellows, Jessica Lambert, one of our former fellows, is the first author, and Eliza Gear is the senior author. And this was a very important study because it showed, this was in pituitary Cushing's, but what it showed is that the longer you had cortisol, excess cortisol exposure, the longer the deleterious effects lasted. And sometimes they lasted a lifetime, even once the situation was cured. So if we extrapolate this to the situation we're discussing about adrenal mild hypercortisolism, it means that even though it's just a little bit too much, if it's over time, that unfortunately is going to be deleterious even once you fix it. And then increased cardiovascular risk. This is the recent data that really made everybody in the field sort of stand up at attention because of this data. So hypercortisolism and cardiovascular mortality. there was an explosion of articles in beginning in 2014. This was from Androulakis, and patients with apparently non-functioning adrenal incidentalomas were at increased cardiovascular risk due to increased cortisol secretion. There were 60 patients with adrenal incidentalomas versus 32 controls. They further stratified these patients into 26 that they said had subclinical Cushing's, and here they did the in-between definition. Dex suppression, their cortisol levels were greater than 3 micrograms after Dex, and 34 that were less than 3 after Dex, which may or may not have had some mild hypercortisolism themselves, who had non-functioning adrenal incidentalomas. And there was basically a continuum in terms of cardiovascular mortality. So subclinical Cushing's was worse than the so-called non-functioning adrenal incidentalomas, which might have been a little bit functioning, and they were worse than the controls. The largest study came out in The Lancet in 2014, Dalmasi et al. And this was a large retrospective study, 198 patients. 114 of them had stable, non-secretory adenomas. 61 were stable with sort of subclinical Cushing's, and 23 during the course of it had a worsening pattern. So this is looking at the percent with cardiovascular disease, and you can see a really clear-cut separation here, the proportion with cardiovascular disease. These are the ones with subclinical Cushing's, and these are the ones that did not have subclinical Cushing's. And this was the 23 with the worsening pattern who had the worst incidence of cardiovascular disease. And then in this study, they looked at all-cause mortality, and the proportion surviving is here on the y-axis. And again, you see this is the worsening, that small group that were worsening. These are the ones with subclinical Cushing's, and these were the ones with no evidence of cortisol hypersecretion. And you see that all-cause mortality and specifically cardiovascular-specific mortality was increased. So the final study I want to show about cardiovascular disease in adrenal incidentalomas was from Morelli. And this was 206 patients with greater than 5-year follow-up with adrenal incidentalomas. And here, their definition of subclinical hypercortisolism was just they needed to not have suppressed to less than 5. Or they gave another choice here, at least 2 of the following: a low ACTH, a high urinary free cortisol, and non-suppression to less than 3. They found 24 patients who had this mild hypercortisolism initially, but 15 more developed it over time. And so that was a total of 8.2%. And some of those, the Dex suppression, originally they suppressed to less than 1.8 initially, but then they met their criteria as time went on. So, and in both the subclinical and in the ones that they defined as non-secretory, many of them grew over time. They didn't grow logarithmically, but they grew slowly, and they began to note bilateral adenomas. After all, whatever this is, whatever the process is that makes you grow one can make you grow more than one. So the subclinical hypercortisolism patients had more diabetes and cardiovascular events and larger adenomas. And they actually found a cutoff size. They said that once these adenomas get to be more than 2.4 centimeters, you really have to be highly suspicious that they're misbehaving regarding cortisol secretion. Cardiovascular events correlated with Dex-suppressed cortisol between 1.5 and 2. So again, we're back to the old definition. After dexamethasone, 1 milligram at 11 p.m. at night, the next morning, your cortisol level should really suppress, unless you're on a birth control pill, to less than 1.8 micrograms. So what's in a name? I I submit that any disease that has these sequelae, which seem to be mounting every time I open up one of the journals, is not really so subclinical. Subclinical kind of suggests that treatment is not necessary. So I would say that the name should probably be changed to mild hypercortisolism. So what are the treatment options? I started off by saying that one of the reasons that we had these looser definitions or fuzzy definitions of what is hypercortisolism from adrenal disease is because the end game was really a unilateral adrenalectomy. And so you want to be certain that somebody really has a disease before you, as an internist, you refer them for surgery. So there was a systematic review of the surgical treatment of subclinical Cushing syndrome, which was fairly recently, I think this was from 2015. They screened 105 patients and selected 7 of them. Laparoscopic surgery was the preferred method, and that is the preferred method for doing an adrenalectomy. They showed improvement in hypertension and metabolic parameters. However, there was so much heterogeneity, particularly in the definition of mild hypercortisolism or subclinical Cushing's, that in the low quality of data precluded any definitive recommendations. So do we have any other options? Any medical options? And the answer is yes. There's been a relative explosion of new drugs for Cushing syndrome in the past few years. So I'm just going to walk you through this. Let's see how much time I have. Oh, I'm good. If you have pituitary Cushing's, that is ACTH overproduction from a pituitary microadenoma usually, occasionally macro, you can use cabergoline, which many of you in the audience know we use as it's a dopamine agonist that lowers prolactin. But it turns out that if you give it in very high doses, a certain percentage of pituitary Cushing's will respond to that. And so that is used for pituitary disease. And then a newer agent on the block is pasireotide. So this one attacks the somatostatin receptors, which are expressed on most of these pituitary ACTH-producing adenomas. And it's different than octreotide in that octreotide attacks mainly, there are 5 subtypes of somatostatin receptors. Octreotide mainly attacks subtype number 2, and pasireotide is active against subtype 2 and number 5, which is more expressed on these pituitary adenomas. So, but that is not an option for adrenal Cushing's. That won't do anything for adrenal Cushing's. So then we have the adrenal steroidogenesis inhibitors. And many of you are familiar with the antifungal agent, ketoconazole. That one is still available to us. If you want to use it as an enzyme inhibitor to treat florid Cushing syndrome, you have to give it in pretty high doses. So its antifungal actions are maybe at 200 milligrams a day, but for adrenal Cushing's or any Cushing's, you have to give 600 to 800 milligrams a day. And it has, in many patients, a lot of liver toxicity. And so we're a little bit limited, although we do still sometimes use that. Metirapone blocks the last step in cortisol synthesis. It's been very difficult to get in recent years, and so we don't have that as a tool. It's making a big comeback in Europe for this purpose, and there are some clinical trials going on, but it's not yet available to us here. Mitotane is an adrenolitics agent. It's a chemotherapeutic agent that we use in adrenal cortical carcinoma. And again, there are some studies in Europe, because this has a lot of toxicity in the higher doses. There are some studies in Europe where they give it for mild hypercortisolism, but in much lower doses. But we're not really using that here in the United States yet. Etimidate, if there were any anesthesiologists in the audience, you probably know that one. That's an adrenal steroid inhibitor, steroidogenesis inhibitor, which is an anesthetic agent. We've used it a few times here in patients with severe Cushing's who are in the ICU and being prepped for surgery. And so the anesthesiologists help us with that. And LCI 699 is very similar to metirapone, and that's in clinical trials here in the States, and it has been published on and used in Europe. So actually, of these, the only one that is really viable here for us here, if I wanted to treat a mild adrenal hypercortisolism, would be the ketoconazole, which has its issues. So mifepristone, this is the old abortion drug, which has been renamed and repurposed, renamed for obvious reasons. It's an abortion drug because it's an anti-progesterone receptor agent, but it's also an anti-glucocorticoid receptor agent. And so mifepristone works differently. It doesn't block the production of cortisol. If anything, if you measure cortisol levels of patients who are on mifepristone, they're probably higher than somebody not on mifepristone. So as endocrinologists, we don't love this drug because we love to measure things in the urine and the blood, and you can't use those measurements as an indicator of what's going on at all. So mifepristone blocks glucocorticoid receptor action. It does not block the mineralocorticoid receptor at all. And so, as you probably know, cortisol can have some actions at the mineralocorticoid, and it doesn't block that at the mineralocorticoid receptor. So there was a funny editorial by Peter Traynor, who's in the UK. He said, innovations in the medical management of Cushing syndrome seem akin to London's red buses. None come along for ages, and then 3 arrive together, namely mifepristone, pasireotide, and LCI 699. So the mifepristone study, this drug was approved by the FDA because this is sort of an orphan disease based on 50 patients, 50 patients. This was called the seismic study. Again, flipping back, this was not for what I'm talking about. It was not for mild adrenal hypercortisolism. These were patients with florid Cushing syndrome, mainly from pituitary diseases that could not be cured surgically. And what they showed, because they can't follow cortisol levels, they have to show an endpoint, a biological endpoint that they improve. And what they showed, and the reason it was approved, this is the area under the curve for glucose, and this is the oral glucose tolerance test. Each patient served as their own control, and this was at 24 weeks, which was the length of the study. They showed significant improvement in all of the glucose parameters. And this is also, I don't want you to focus on all of this, but it just shows you that also their weight went down almost uniformly, their waist circumference went down, they had beneficial changes in body composition. So we started, I want to say 2 years ago, but it might have been even longer than that. We had an idea that in these patients with mild hypercortisolism, if they have at least glucose intolerance, perhaps we could do a little pilot study giving mifepristone with the thought that it was almost like a therapeutic challenge. And what I mean by that is that these patients had features of the metabolic syndrome, particularly glucose intolerance or sometimes frank diabetes. And if we could show that by blocking down cortisol action, we could actually make them better, then maybe there'd be a rationale for sending them for surgery. Because we're often in a conundrum with these patients. So the hypothesis was that patients with mild hypercortisolism due to benign adrenal disease will benefit from glucocorticoid blockade with mifepristone in terms of glucose control, weight, waist circumference, and depression and anxiety measures. It was supposed to be a pilot study of 20 patients with an incidentally noted adrenal nodule or nodules, mild elevations in cortisol levels, and diabetes or abnormal glucose tolerance testing, and no other features that would force our hand in terms of recommending an adrenalectomy, meaning no worrisome features for malignancy. And this is an IRB-approved study, which is still ongoing. And this is what's involved. Initial visit and 6-month follow-up, they get a fasting glucose, hemoglobin A1C, HOMA-IR, weight, BMI, waist circumference, blood pressure, fasting lipids, And then a whole bunch of questionnaires that they have to fill out, appetite quantification, depression scales, several of them that have been validated, anxiety scales, and there's a Cushing's quality of life scale that is very useful. So I'm going to show you some of the results. We reported last year at the Endocrine Society, and now we have an update. This is coming up April 1st is our Endocrine Society meeting in Boston, and this has been accepted for presentation. But this one this is the one I'm not going to put on my slides because we didn't present it just yet. Essentially, there were 17 patients that were screened, 10 who met the criteria. Of those 10, 1 elected not to enroll, 5 completed the full 6 months, 3 completed at least 2 months, usually 2 to 3 months, and then stopped for a variety of reasons, but not due to toxicity. And then 1 withdrew due to a really severe drug rash at 2 weeks. So we looked at all these different parameters. I'm going to show you the most significant. Waist circumference, until we had this last patient who just clocked in, who was on it for 3 months, patient number 15, this actually, we had a reduction in waist circumference that met statistical significance, even though it was very few patients. However, this gentleman's waist circumference did not change, and so the t-test did not quite make significance once we included that last patient in. But HOMA-IR, we could only include 6 patients because the others were on insulin, so you can't do a HOMA-IR on them. And here we did have a significant reduction in the HOMA-IR, which is a measure of insulin resistance. So to refer potential patients, we have Nandita Sinha sitting right over there. So if you want to refer any patients to the study, we'd be happy to accept them and to screen them. And what I wanted to get across here, this is my summary slide, is that adrenal Cushing, adrenal incidentalomas are increasingly common. As many as 30% may be producing small amounts of excess cortisol. Subclinical Cushing is not so subclinical. Even low levels of excess cortisol can contribute to obesity, metabolic syndrome, osteoporosis, cardiovascular morbidity, and mortality. And treatment options include observation, which we often do, surgery, and new medical therapies. So I want to thank you, and I want to thank the fellows. This was a totally fellow-driven project. Jillian Goddard started it and basically spent her research year trying to get the IRB through. And she did it by the end. And then Arti Ravikumar took up the baton, and then she really did most of the heavy lifting on the data that we have so far. Nandita is now working with me to complete these studies. And Eliza Gear has been my co-pilot in this project. And then I want to thank my husband, Alex Kirschenbaum, who always helps me with all things academic. He is a clinical professor of urology, and I want to give him a shout out because he's one of the Jacobi Medallion winners this year. Thank you.
Thanks, Alice. That was fantastic. We have time for some questions, but I would like to just ask a quick question. So in the, thinking in the primary care clinic, your metabolic syndrome patient with hypertension, obesity, osteoporosis, maybe, should we be doing low-dose dexamethasone suppression tests in this patient?
Okay, so I'll repeat the question, though you speak very loudly, but who do you screen for this? So anybody with an adrenal incidentaloma should be screened for this, okay? And the main screening really is, the go-to screening for this is dexamethasone suppression test. So if it's a female who's on a birth control pill, you have to stop the birth control pill to do that. If you flip it the other way around, we have a lot of obese patients, a lot of hypertensive patients, a lot of patients with prediabetes and diabetes, and a lot of patients with osteoporosis. It's hard to answer that question, but it looks like if somebody has unexplained osteoporosis, meaning it's someone where you expected to get a good bone density and you got an unexplained osteoporosis, it's worth it to screen for Cushing. If somebody has glucose intolerance, diabetes, and some other features, probably worth it to screen. In patients who are just obese, it is not worth it to screen. In terms of the incidence is so low. So that probably doesn't deserve the screening. And hypertension, controversial. Controversial hypertension.
Other questions? Yes.
Are there significant consequences of doing the adrenal activity? And has anyone tried to do greater frequency ablation of the nodule?
I don't know. The answer to the second question is I don't know. And they don't usually even do selective adenomectomies. So the question is, are there adverse consequences? Well, as my husband, who is a surgeon, says, don't let them fool you. There are no small surgeries. So having said that, laparoscopic adrenal surgery in good hands, such as we have Dr. Fernandez Ranvier is fantastic here, Dr. Nabnet is fantastic. You know, it should be a relatively straightforward procedure. Most patients can live very well with one adrenal gland. If they had mild hypercortisolism prior to the surgery, then the other adrenal gland, the contralateral one, if it's not also hyperfunctioning, will be suppressed for a while. And so you do have you have to know that going into it, and you have to give them some cortisol, sometimes for as long as a year, some cortisol replacement therapy. But other than the risk of surgery and hypocortisolism from suppression, not too much.
Thanks very much. Nice presentation. What's the possibility in your mind that the cortisone, the adrenal, is not causing these end results, cardiovascular, diabetes, but that they're both due to a third yet undiscovered factor? The tumor grows and these other side effects occur, but they're not cause and effect.
So the effects, cortisol has direct effects on insulin resistance and on the osteocytes and osteoporosis. That's pretty clear. It has both direct and indirect effects on hypertension. So cortisol, the effects on hypertension are complex. I think that most of the evidence would say that too much cortisol is the main factor here. There's always a possibility that there's something else. But cortisol is implicated, and there's plenty of basic science to back that up in terms of the three major morbidities: hypertension, glucose intolerance, and osteoporosis.
Roy?
Back to Yusuf's question, does the size of the incidental or characteristics on CT scan, would that drive you to either get a dexamethasone suppression test or not? I'm just trying to hone it in for primary care.
Yeah, so for me, because I co-direct the adrenal center and I see lots of patients, it's a big, it was interesting. When we first formed this center, which was in 2010, I've been here a long time, as you heard from my introduction, and I'd seen a lot of centers come and go. So when Barry Nabnet from surgery came to me and said he wanted to make a center, I said, sure, put my name on the letterhead, thinking it would just go away. But it didn't go away, because even endocrinologists are a little bit uncomfortable with adrenal. So for me, anybody who's referred to me with an adrenal incidentalloma, and they usually have some feature of the metabolic syndrome, I'll do a dex suppression. For primary care doctors, what the last study showed was that there was a size cutoff when you started to worry, and that was about 2.4 centimeters. So if you get a little 1 centimeter, that's more likely to be an aldosteronoma. Those tend to be real small, between 1 and 3. And as a matter of fact, if somebody has primary aldosteronism and they have an incidentalloma that's greater than 3 centimeters, it's probably true unrelated.
Dr. Cole?
Yeah, it was great, Alice. I was wondering if you sort of factor out the hypertension and the diabetes, is there really accelerated atherosclerotic cardiovascular disease progression that's due to the cortisol separate from those secondary events?
It's a good question, and it's hard to do. There was one study that came out right before that Dalmasi study, which just looked at, what's the word, it just looked at one measure of cardiovascular, I'm blanking on what it exactly was that they looked at. And there they teased out people without diabetes and without hypertension, but it's very difficult to do because usually it's all in the soup here.
Great talk, Alice. I had a question about the mifepristone studies, the ones that were from Europe, and then the one that you did. What was the patient's blood pressures in those cases? Because you said that that drug doesn't have an effect on the mineralocorticoid receptor, so and the cortisol levels might be higher.
So mifepristone is it's a tough drug. It's a tough drug from the practitioner's standpoint because. As I did mention, sometimes it lowers blood pressure. In that original seismic study, some of them had a lowering of blood pressure. But as mentioned, cortisol acts at the mineralocorticoid receptor. And so what usually, cortisol actually works fine, as well as aldosterone. Usually there's a mechanism in place that inactivates cortisol to cortisone. And cortisone cannot bind and activate the mineralocorticoid receptor. However, in Cushing's, or when there's too much cortisol, it overwhelms the ability of that 11-beta-HSD enzyme to inactivate it. So in some patients, and in the last patient who I said we just added the data, they actually get a worsening of hypertension and a worsening of hypokalemia. And when he came in for his 3-month visit, he hadn't been feeling well, and his potassium was 2.8. So, it is you have to monitor these patients.
Any other questions? Great. Well, let's thank Dr. Levine for a great talk.